Thank you all for joining us today. My name is Dr. Bukowski, and I'm the Medical Director for the Diagnostics Division here at Hologic. And today I'm going to be joined by two fabulous colleagues discussing applying the continuum of care to strengthen STI management. This is an incredibly important topic, one that never ceases to need more discussion. But before we get started, I want to introduce my colleagues who are going to be joining me today. First, I'm joined by Dr. Stewart, who's a family physician and lead HIV specialist with Cooperative Health in Columbia, South Carolina. Dr. Stewart completed her medical degree at the Medical College of Ohio and her family medicine residency training at Palmetto Richland Memorial Hospital in Columbia, South Carolina. Dr. Stewart has additional certification in HIV care from the American Academy of HIV Medicine and as a hospice medical director. She has held many leadership positions on the local, state, and national levels, including serving as the first African-American female president and board chair of the American Academy of Family Physicians, as well as achieving the rank of colonel in the U.S. Army Reserves, where she continues to serve. Dr. Stewart is a staunch advocate for marginalized populations, including those living with HIV/AIDS and those with the trans experience. I'm also joined today by Dr. Tonya Chaffee, who's a clinical professor of pediatrics at the University of California, San Francisco at Zuckerberg San Francisco General. She's also the hospital's medical director of the Child and Adolescent Support Advocacy and Resource Center and director of the Teen and Young Adult Health Center. Dr. Chaffee completed her pediatric residency, chief residency, and subspecialty fellowship training for adolescent medicine at the University of California, San Francisco. She then completed an academic fellowship in violence prevention through the California Wellness Foundation at San Francisco General Hospital. During this fellowship, she earned her master's in public health at UC Berkeley while conducting research and policy work in violence prevention. Dr. Chaffee is passionate about advancing the education of providers and caring for adolescent and young adults. Thank you both so much for joining me today. So to kick us off on this discussion, I'm going to do a couple introductory slides, setting the stage for the current state of STI management in the United States. And then most of this is going to be a roundtable discussion with these fabulous guests to really talk about the nuts and bolts of how we manage STIs and we can be doing a better job managing sexually transmitted infections. But I first want to introduce this concept of the STI continuum of care. Many times we think about STI management as episodic and opportunistic, meaning we think about somebody coming in, wanting testing, wanting screening, we test, we screen them, we move on with our day. And we really want to reinforce this concept that STI management really is a continuum, something that we should be managing throughout the lifespan of these individuals and at regular touch points when we're interacting with them as healthcare practitioners. So obviously it starts with awareness, people being aware that STIs are an issue and something they need to think about to protect their health. Then we move on to screening for the asymptomatic population, thinking about symptom management and evaluating symptoms appropriately. When somebody does have an infection, treating them appropriately, and then not forgetting the needs for potentially retesting to ensure that we have tested for reinfection, and then talking about strategies for long-term protection from STIs. This continuum is what we're going to reinforce in our conversation today, and something that we should all be thinking about as clinicians who manage patients who may be presenting for or need care for STIs. So building STI awareness really starts with understanding what the numbers look like. And untreated STIs continue to be a significant issue in the United States, and we know that they can lead to serious health problems. We also know that they affect different groups differently, right? We know that young people, gay and bisexual men, pregnant women, and racial and ethnic minority groups have higher burden of infections and maybe higher burden of morbidity or long-term sequelae from these infections. And we know that there continues to be a lot of new infections every year. So we know that if we look at the 2024 provisional data released from the CDC last year and looking kind of back around 4 years back to 2020, and what we've seen is actually a decrease from 2020 to 2025 for chlamydia and gonorrhea, about 4% and 20% for gonorrhea. But you're still seeing, right, 1.5 million cases of chlamydia, over 500,000 cases of gonorrhea. And the other part that we're not totally seeing here is how much infection are we missing because people have not actually returned to asymptomatic screening following the COVID pandemic. Right? We only know as much information as people are being tested. If people aren't being tested, we don't know what the burden of untested disease is. And so we have to look at these with some understanding that this may represent true decrease in incidence of infection, but also could just represent a decrease in screening and we're having missed cases. And the reason that I bring this up is we still see rises in syphilis and particularly congenital syphilis since 2020, which is an indicator that there is still disease spread and there's still infection spread happening that we're just not catching. We know that we are often catching syphilis and obviously congenital syphilis in the case of pregnancy, or in patients who are presenting for PrEP care or things like that, where they're getting screened more regularly. And so they're in a more tight pipeline to look at those infections. All right, moving on. We know that, again, in young people, they have the highest burden of disease. Even though they account for 13% of the population, those age 15 and 24 account for almost half of new infections in the United States, 42% of gonorrhea cases and 62% of chlamydia cases. And this is particularly important because we know there can be long-term sequelae from these infections, right? These untreated infections can, particularly for women, lead to PID and infertility, with over 30% of untreated chlamydia infections progressing to pelvic inflammatory disease, which can result in nearly 250,000 women becoming infertile every year due to undiagnosed STIs. As a gynecologist myself, I often think about this image, very commonly when I'm talking to patients about the impact of STI testing. So this is a diagram of the uterus, and we have a kind of normal fallopian tube on the right and a not so normal fallopian tube on the left. On the right, we see this normal, healthy tubal structure, and we zoom in onto the lumen of this fallopian tube. We see this healthy ciliated mucosa that's able to move a fertilized embryo down to the uterus if fertilization were to have occurred. And on the left, we see the consequences of untreated chronic infection and salpingitis, potentially leading to pelvic inflammatory disease, where we see the tube is engorged, it's erythematous, the lumen is thickened, and the mucosa has lost that healthy ciliated structure, and now we have all this fibrinous exudate and scar tissue that's formed. And this is why we get the long-term sequelae of potentially tubal infertility, increased risk of ectopic pregnancy, chronic pelvic pain, because this has now become a maze where maybe sperm can make their way through, cause fertilization, but then that embryo, which is much larger, can't make its way down the tube. Or there's complete occlusion of the fallopian tube, and now you have tubal infertility where egg and sperm cannot meet, fertilization cannot occur. And these are both potentially lifelong consequences for these patients. This is also in the setting where in the United States, access to fertility management and assisted reproductive technologies is not equitably distributed across the population. And so this does become an equity issue when you think about the burden of disease in young people, and then also access to maybe overcome some of these fertility challenges is also not equitably distributed. So hopefully that sets the stage for understanding why having a conversation about sexually transmitted infections is important and why we need to continue that conversation. And to support prevention of these long-term morbidities, we have quite strong screening guidelines, right? So the CDC, the American Academy of Pediatrics, ACOG, family medicine physicians, and the U.S. Preventive Services Task Force all recommend strongly sexually active women under the age of 25 be screened annually. Women 25 and older who are at increased risk, and we'll talk a little bit about what that means, should still be screened. Pregnant women should be screened, and men who have sex with men should be screened on an annual basis. And so now I'm going to bring in my colleagues to start having a conversation about this. So looking at current STI screening guideline recommendations across different populations, young women, pregnant women, groups at high risk, Dr. Stewart, where do you feel they work well, and where do you feel they are insufficient?
So thank you so much, Kyle. It's really important that we realize that in the guidelines, it says at increased risk. Most of the time, our population, our individuals who are over 25 don't even realize their risk, as well as clinicians they're not able to realize risk. And we have to be cautious when we use that word risk. Because risk can be stigmatizing, and that's one of the huge problems that we have in the population that we're trying to address and get these individuals screened. When you think about, telling someone that they are at increased risk, then all they can think about is the negative consequences of that. Are you saying that I am a bad person? It just brings about all these stigmatizing things. And so for those populations that fit into that category, it doesn't quite work. And so then we need to do something more. We talk about during sexual histories, doing a deeper dive into talking to our patients about what that looks like, what taking care of their health looks like, and not necessarily addressing what we would call as this risk-based therapy. So again, looking at making sure that we do some type of universal opt-out screening, which I know we're going to talk about coming up. Those are the things that, again, that we need to consider. Making sure that we are able to get this population that has been underscreened due to no problem of their own, but a lot of times the onus is on us as clinicians being able to address and be able to find out, how can we do better with assessing the vulnerability of this population.
I completely agree. And Dr. Chaffee, what are some strategies that you use or that exist to improve the uptake of screening in a population, particularly in an at-risk population like adolescents, for example?
Yeah, and thanks, because this is an important discussion, and I know I was sort of biased in how the first topic of sexually active women. So women is one risk factor, if you want to apply it to that, and age is another factor that we talked about. And then this assessment of sexual activity in pediatric populations and younger adolescents, it's easier said than done to ask someone if they're sexually active. There's a lot of things we'll get into around how that's determined, but all those become barriers, both at the patient and the provider level, on how we assess that, quote, risk of being sexually active. And we can talk about whether sex is a risk or not, but in a lot of adolescents, we kind of put that bias in our head around being risky if you're sexually active. So that allows us to miss a lot of opportunities for screen. And, there's a lot of studies that we'll talk about that, young people say they're not sexually active, but they have an infection because there's things going on around why they didn't disclose this. So a way to get around a lot of that, and we did this in my own pediatric practice, as well as the wider health system, when we were looking at sort of doing quality improvement initiatives and actually focusing on disparities. As we mentioned, certain populations are burdened with sexually transmitted infections, and we wanted to address those. So we started a chlamydia screening with a wider population of, including adolescents, but the whole, female population of patients that we're caring for, to kind of address that we weren't screening well. And then nationally, we're still not screening well. So we went from, doing risk-based assessment, quote unquote, and asking about sexual activity, as well as like number of partners, which is another, when you look at older women, that's what included is determined increased risk, is if you're having more than one partner, which already puts in some bias and stigma into the question itself. So we went to sort of asking, not even asking if people were sexually active, but just letting them know we wanted to test them, which we kind of moved to sort of universal screening and opt-out. And I wasn't actually really on board with that initially. And I said, I think you really need to get to know your patients. And I was sort of not, thinking this is, they need to know that this test is being done and so forth and so on. But wow, did our screening rates just go sky high when we went to this. And I learned that, young people really wanted to be tested. They didn't know, that they could be at risk. And they could make their own self-assessment in their bubble over their head. But at the same time, they sort of understood that, I'm becoming an adult now, and they're now going to, it's kind of like the badge of honor in a way. So it kind of flipped it on its back. And actually parents were really glad that, we were having these conversations and talking to their kids about this and protecting themselves and so forth. So there are a lot of ways to sort of address this. I know these are the guidelines right now, but the CDC has actually, in the adolescent population, recommended the concept of considering universal screening and opt-out in order to sort of reach those harder populations that may not want to disclose what their risk behaviors are, if you want to call them risk behaviors. I just think sexual activity should not be a risk behavior, but that's me.
I agree with both of your points. And I think sometimes our systems don't also support us broadening our screening perception, even just the way that we code these things, right? So just with the Affordable Care Act and coverage of this as a preventive service, right, we have a guideline that says sexually active women under 25 years old. That bar is pretty easy to typically hit, especially if somebody's coming in requesting screening. But the increased risk piece, right, adding on these codes that are a little archaic and have language like high-risk heterosexual behavior, high-risk homosexual behavior, right, they come, to your point, Dr. Stewart, with a lot of stigma and, emotional weight attached to them. Even when the person is just looking in their chart, looking for their results, and they see this diagnosis code attached to it, it can be problematic. And I'm sure we've all had experiences where we get a message or something back, saying like, why is this in my chart? Well, it's it's because you wanted to be STI tested and you're 30 years old because you have a new sexual partner. It's problematic, and it brings in a lot of stigma that's probably not helping. But we also want to make sure that there's no cost sharing for the patient and that they're able to access this care affordably, and that all matters. So as you mentioned, we know that patients are often asymptomatic when they have these infections, right? So over 84% of gonorrhea and chlamydia infections are asymptomatic at the time of diagnosis. And when these infections are asymptomatic, patients are unaware that they have them, and they can lead them to be undiagnosed and untreated and have, again, lifelong sequelae. But there is this additional kind of layer of all these barriers that you both raised so beautifully that can affect uptake of screening. There are barriers on the healthcare practitioner clinician side of those, right? So we assume that patients are low risk by the way that they look, or because we have a relationship with them, or what they're telling us. We may think it's time consuming to have a robust conversation about their sexual history. If we're dealing with adolescents, we may be concerned about our ability or the practice's ability to maintain confidentiality. We may want to just avoid difficult conversations, and we may be worried about reimbursement for the care. And on the patient side, they can equally assume low risk, right? Many patients don't know that the sex that they're having puts them at risk of STIs, just because they have not been educated. We can have a whole separate conversation about the quality of sexual education that's accessible to young people in the United States. Obviously, embarrassment and stigma of just not wanting to have the conversation. Again, if they have a parent in the room or some other person that they don't want to hear this information. And then again, just access to testing, right? Getting to a place to get tested can be challenging, especially if you have additional barriers such as age or cost or transportation or all of these things. Altogether, this leads for missed opportunity for diagnosis and participation in screening. And as you mentioned, Dr. Chaffee, right? Almost 2% of patients who report never being sexually active are positive for chlamydia. And it is not from toilet seats or hot tubs. We know that this is just a barrier in language and disclosure. So it is important that we think about systems that can help us achieve better screening. And one of those is universal screening or opt-out screening, right? So a system where, regardless of reported sexual activity, you are recommending and offering screening, trying to remove some of those barriers. So I'd like to hear from both of you, and maybe Dr. Chaffee, if you want to start. What are the practical operational benefits and challenges of implementing opt-out screening in your practice or experience?
Yeah, like I said, I was not on board in the beginning, and we didn't start our QI project by doing universal, but we went to it because we found the benefit to screening. And we know this with other things, for example, HIV screening, when that's why the CDC recommends universal screening, to just not do the risk-based assessment and decide who gets tested and who doesn't. It takes away that. The benefits are you're obviously going to increase your screening rates, and you're going to kind of normalize the idea. And in my practice, we had the little brown bag sitting there when you went to log in to see your patient, a reminder that they just did this urine test. So we did a lot of strategies around how to, streamline things so it didn't take up a lot of time. But I would say now that we've been doing it for several years, we all are kind of Pavloved into the brown bag means send the test kind of thing. And, we have to screen this person. And their MEA, and just getting those workflows in place. It may take a little time in the beginning to get that set up. One thing I will say is we were doing a lot of urine-based testing, which is great because it's easier than doing a pelvic exam in the old days. That was a barrier to screening. Now we can just do urine-based testing and swabbing, but we only had one bathroom for patients. So we kind of had this line. So we had to strategize, okay, well, why don't we do more self-swabs with our cisgender female patients so that they can just, do it in the room before we come in. And it adds a little benefit of sort of self-collection. But these are just some strategies that we use to sort of streamline things. And now it's sort of like even the patients expect this. They know this is part of their routine health of getting the blood pressure, getting some vaccines, and then this test. The other kind of thing that helped out was, some of the guidelines say when you become sexually active. Well, if you had 2 SIBs coming in for appointments, and one was getting the test and one wasn't. It kind of created this awkward situation of why one person was getting the test, getting the brown bag, and the other one wasn't. So now we're universally doing it. It sort of takes away this, why almost the stigma of the brown bag. The brown bag is kind of like a badge of honor now instead of this like this risk-based who gets the test and who doesn't. There's other things to consider, but I think it helped us definitely increase our screening rates. And obviously the testing was higher and we had more infections. And I know we're going to talk more about the management because it is this continuum of care that I think is important when you do this, because you're going to get positives now and you need to know how to address those positives. And if you're not ready to address those positives, you have to kind of build that in, because we did unfortunately have some confidentiality breaches because we didn't get a confidential contact number. And it was trouble trying to assess who to call and trying to talk to a parent about a lab result that we were trying to keep private. So these are things that need to be sort of addressed. They shouldn't be barriers to doing it, but that's that continuum of care you need to understand.
Absolutely. Dr. Stewart, anything to add?
Yeah, I mean, the biggest thing is to get the workflow in place, to have everyone on board from the front to the back. My medical assistant knows, and, again, removing that stigma, normalizing this process, everyone gets the opportunity to be screened. I see from infants all the way up through adolescents, through older individuals, so it doesn't matter at what age. Of course, we ensure that confidentiality is there for our adolescents. Everyone has the opportunity to be screened. And I think with that normalization of the process, you remove the stigma. And so, of course, as Tonya said, you're going to get more individuals who are going to test positive, and then recognizing that that's a perfect opportunity to talk about prevention and other things moving forward.
Great, totally agree. All right, so we're going to move away from screening our asymptomatic population. I think we have some really great tools now to hopefully increase uptake of screening in that population, and talk a little bit about evaluating and managing symptomatic patients. So thinking just in this case about women, but we know that it's, many of these infections are going to apply to men as well. There are a number of overlapping symptoms that can make diagnosis of the actual cause quite challenging, right? Patients reporting discharge, odor, irritation, pain with urination, or sex can be one of many infections or non-infections as well. When we think about infectious causes, we have kind of our classic vaginitis triad, so bacterial vaginosis, Candida vaginitis, and trichomoniasis, and then our STI infections, which trich is a overlapping one, and then chlamydia, gonorrhea, which classically cause cervicitis, as well as mycoplasma genitalium. And so getting diagnostic accuracy is really important when patients are presenting with these symptoms, because us as clinicians cannot make the diagnosis just based off of history and exam alone. Patients often think that they can make the diagnosis just off of history and symptoms alone, and we know that not to be true. And we also know that there can be multiple infectious agents or etiologies happening at the same time, right? Patients can be symptomatic for multiple infections, which may need different management. So, Dr. Stewart, knowing that symptoms overlap and co-infections are common, how does that influence your diagnostic approach? How do you approach a patient coming in with symptoms who maybe hasn't been screened recently?
The important thing is to make sure that we get the right diagnosis the first time. And so I use modalities that are available, such as the multi-testing swab. Those are things that help me to make sure that my diagnosis is correct on the first time. You don't want to have an incorrect diagnosis, have someone have to come back because the symptoms have not gone away, and explain to the patient that I want to make sure that we get this right the first time. Want to make sure that we get you on the correct medication. That's so important. Because again, you talked about the sequelae that could occur, PID, infertility. We want to make sure that this is correct at the first encounter. And so those are conversations that I have with the patient, making sure that we may test for everything, because it could be one, two, or all of the above. there at one time, also including in that, HIV screening as well as syphilis, which would include blood draw. So making sure that at that first time that they come in, because I get individuals who come in who say that I know this is BV. I always get BV. These are the symptoms of BV. Yes, that could be, but we want to make sure, because sometimes BV could be hanging around with some other friends, that we test you for all of the above to ensure that we get the right diagnosis and the right medication treatment at that first time visit.
Yeah, you bring up a wonderful concept, which we've called BV plus, which is this concept of BV and co-infections with STIs. And there is good emerging evidence showing that there is a strong link between BV and other STIs being present at the time of presentation. This was a study that was published in 2024 looking at, it was a vaginitis clinical trial for a vaginitis assay, and they looked at the remnant samples. So these are women presenting with vaginitis symptoms. They were tested for BV, yeast, and trich, both with traditional methods and with nucleic acid amplification testing, molecular testing. But they went back to those remnant samples and said, of those women who came in with symptoms of vaginitis, how many of them had concurrent chlamydia, gonorrhea? We knew we were testing for trich, and then mycoplasma genitalium. And because we know about this link for a long time. And it was a little surprising to see that 1 in 5 women, right, 20% of the population who had BV symptoms had at least one STI. And of BV positive women, they had twice the rate of STI infection, right, 26% compared to BV negative women, which we've had a recommendation from the CDC since 2021 that BV positive women should be tested for STIs. But this data reinforces this concept that these infections can hang out together, that they can potentiate each other, and that we need to be thinking broadly about our testing approach. And whether, I think again about introducing stigma, right? It'd be really easy for somebody who we think is low risk, or they're reporting low risk behavior, as just getting, BV and yeast testing when they come with vaginitis symptoms. But then we're missing out on the possibility that there can be this co-infection present. And the benefit of molecular testing too is, even if you're not thinking about it at the time, when that BV positive comes back, positive, you could potentially call your lab and reflex and add on chlamydia, gonorrhea, MGen testing as needed, if you're using a testing platform that's able to offer all of those tests off of one sample, which is not the case, for urine, which you would be doing urine for vaginitis testing anyway. But just, thinking about, Dr. Chaffee brought the benefit of a vaginal self-swab as another way that you can kind of increase your rate of detection, I guess, if you need to test for more things, and knowing what samples can be sent off of what type of, or what tests can be sent off of what kind of samples. All right, I'm going to move us on to treatments, because we still have lots more to cover. So now we have been increasing our testing, either screening or patients are coming in with symptoms. And as you mentioned, Dr. Chaffee, we're going to get some positives when we do this. That is, I guess, essentially the goal, right, of increasing screening, is finding the people who have infections that we can hopefully treat. So this is a quick look at current CDC recommended STI treatment for our common, curable or treatable STIs. So a couple of quick notes that I want to put out here. This was 2021 CDC treatment guidelines. They've been around for a while, but just some quick reminders. Chlamydia, we moved away from azithromycin as a single gram orally as the preferred treatment, and moved to doxycycline 100 milligrams orally BID for 7 days. But you can still use azithro for pregnant patients, or if you're worried that somebody's not going to complete treatment, there's also the option for levofloxacin if you're worried about allergies. And this move was really not so much due to chlamydia sensitivity to macrolides, but more gonorrhea, right? We've seen increased macrolide resistance in gonorrhea. And so we're trying to reduce the exposure of gonorrhea isolates that may also be present when treating chlamydia by moving to doxycycline, which is still quite effective. For gonorrhea, again, because of that increased macrolide resistance, we used to co-treat with ceftriaxone and azithromycin. We've moved away from that for uncomplicated gonorrhea infections to weight-based ceftriaxone dosing, so 500 milligrams IM once for patients under 150 kilos, and a gram IM for patients over 150 kilos. If you have a high-risk cephalosporin allergy, then you would use the gentamicin and azithromycin combination. And if you have a patient who is unable to come back for parenteral antibiotics, you can do cefixime 800 milligrams orally once. Though really this should be mostly reserved for expedited partner therapy, which we'll talk about in a second, or someone just like literally cannot get back to the office because the gold standard is definitely parenteral antibiotic for gonorrhea. For trichomoniasis, we moved away from the 2-gram oral single dose for both men and women so that men can still do that, but women should actually be on the 500 milligram BID dosing for 7 days, similar to trichomoniasis treatment. And then lastly, MGen, which is still maybe a little more challenging for many people. There is guidance to treat Mycoplasma genitalium based on your understood macrolide sensitivity because MGen isolates have very high resistance to azithromycin and macrolides. It can be as high as 70% of isolates in some settings. Now, that being said, there is not any commercially available macrolide resistance test currently on the market, so it really be based on whether the lab is offering a macrolide resistance testing at this time. If you do know if they're macrolide sensitive or not, then you may do a doxycycline azithromycin regimen, which is listed here. If you know they're sensitive to macrolides, but if you know they're resistant to macrolides or you just don't know the resistance status, then you do doxycycline 100 BID per week and moxifloxacin 4 milligrams daily for a week. So that is current treatment guidelines. You know, always rely on your CDC app, your little quick card, like whatever it is to manage these, make sure you're up to date. We do expect that there will be new CDC treatment guidelines coming out within the next year, most likely starting with chlamydia and gonorrhea infections, potentially as early as the summer, as some have speculated, but we've not quite seen them yet. So this is, again, current management recommendations. But in addition to treating patients, we also need to think about the concept of treating partners. And so, Dr. Chaffee, I want to ask you a little bit about expedited partner therapy. So this is the concept of providing treatment to the partner of your patient for the infection that they've been diagnosed with. You know, how is this being used in your environment, and what are some of the biggest barriers you've seen to using expedited partner therapy?
Yeah, I think, and this is a thing, like when you get these positives in this continuum of care, you want to treat, but this is not like strep throat because there's another person or persons that you may have to notify. And so ideally, in the best of all possible worlds, you get all partners treated with the plural. But obviously, you can imagine the barriers. And some people don't even know that that's something that they should do. They're treat chlamydia like a strep throat. No. You're going to have to make sure partners are treated because one of the continuum of care is retesting and rescreening to make sure that they didn't get reinfected. That is rescreening in 2 to 3 months, which was recommended by the CDC. And the reason for that is because partners are ideally treated. But this is, you know, you can look, this shows you sort of the map. And it gets tricky because state laws vary on what infection you can treat a partner for, how you treat them. Obviously, as we talked with gonorrhea, it's an injection. So it's a little more challenging to, you have to usually ideally have a partner come in. Now, do they have insurance? That's a huge other thing. And then there's, as listed here, there's barriers at the pharmacy level. Well, you may not understand why you're giving this double dose to a patient and that patient's giving half to their partner or partners. And you can imagine, like, you know, navigating that. Then there's, I always go down the path of like, it's kind of sometimes a fidelity test. And there may be non-monogamous relationships happening. And how does a person tell a partner? And this can get pretty serious because we've had married patients come in that had chlamydia and they were negative, 8 months ago. So these are things that you have to think about when you're setting up your sort of workflows on treatment of the patient as well as partner treatment. And as you can see by the map, all of them allow some form of that, but this is really knowing, and you can always contact your public health department to sort of identify what are the regulations and laws. And then also sometimes you have to educate the pharmacists on what is allowed and what isn't, because there may, again, there also may be insurance issues. So there's a benefit, and we know, and this is why they have these laws, is because it does reduce the reinfection. And you're actually, if you're diagnosing one person, you may be diagnosing 3 or 4 cases of chlamydia in your, population, if you look at it from a public health perspective. But getting those people treated has its own hurdles.
Dr. Stewart, anything to add?
Nothing really, but, just recognizing and being aware, that this is a thing, that we can treat the partners and that we should. But as Dr. Chaffee said, Tonya said, we have so many barriers that prevent that.
Yeah, I mean, I think the pharmacy is a huge one. Pharmacists not being aware of this, understanding what the rule is in your state where you're practicing for how it actually gets done is important. And then not missing the opportunity to still recommend that those partners ideally go in and see, a healthcare practitioner to be screened for other things, right? Like syphilis, like HIV. Talk about what other sexual health strategies they can use to maybe prevent reinfection. We're going to talk about a few of those in a little bit, but I think that's all important that we continue to reinforce that, just writing the script for that extra dose of doxy we can be doing more than that, right? We should at least be doing that at a minimum, but we can also be doing more than that. And it's somewhat the ground level, I would say, is expedited partner therapy. But really, really important strategy from a public health perspective. Now, we talked a little bit about BV earlier, and I think this is a great time to think about expedited partner therapy or partner treatment as a strategy to reduce reinfection. There was some really exciting data that came out in 2025, especially again as a gynecologist, around BV. And we talked about lots of conversations about whether BV is an STI or not. Right now, it is not considered an STI, but there is obviously some sexual transmissibility of BV. We know that it's more common in sexually active people. I've had many patients tell me, like, I get BV from that person and not that person. Like, we know condom use can reduce BV recurrence. So we know there's some sexual nature to bacterial vaginosis. And there was a paper that was published in JAMA last year, which was really interesting, where they looked at actually treating male partners of women with BV, recurrent BV, and what they saw is a 50% reduction in the recurrence rate of BV in women whose partners were treated, right? So the partner was treated with topical clindamycin and oral metronidazole, and saw this really drastic decrease. And actually things in medicine go slow. I've never seen something adopted so quickly as I did this data in clinical practice, where providers were quickly talking to their patients about treating the male partner. And so fast that even ACOG came out with practice recommendations like in less than a year after this study was published. And so it's really exciting to see because I think, again, thinking broadly about how do we treat the whole, group of people who may be having sex, whether it's monogamous partners, whether there's multiple partners, whatever it is, how do we think about that whole pod of people as somebody that can be treated to reduce reinfection and reduce the risk of ongoing cases? Now, a couple of things that are particularly interesting. The study was done in recurrent BV cases, but the author actually said, we only had recurrent BV patients because they were so motivated to participate in the study, because they were obviously miserable at having multiple episodes. But really, we can be thinking about treating male partners with, or any partner with the first presentation of BV to hopefully break that cycle early on before it becomes an issue. So I think it's really exciting for us to be thinking broadly about, this is not expedited partner therapy. This is not something where you can manage a patient with BV and write a script for the male partner. But one thing that a colleague of mine did is they created a whole letter basically. So if the patient had BV and they were getting treated, they would give that letter so that the partner could bring that to their clinician and say, hey, it's recommended that I get this treatment because my partner has BV and it's going to help reduce the risk of reinfection, with the study and everything attached. Now that's a lot of work, but sometimes this is what it takes, right, to get these things in the water and to help guide our colleagues, because if you don't manage BV normally, and then you may not know that this is a thing, but you may be taking care of that male partner. So, all right, we introduced the concept of retesting. So now we've screened our patient, or we've evaluated our symptomatic patient, we have tested them, we have treated them, and now we're at the next step of the continuum, which is retesting, right? It's really, really critical that we bring patients back and test them for reinfection because we know that reinfection is quite common and many people do not come back for that recommended retesting. So as a general reminder, for chlamydia, gonorrhea, and trich, it is recommended to be retested at around the 3-month mark. For chlamydia diagnosed in pregnancy, there's a test of cure recommended at 4 weeks to make sure that the infection was eliminated, and then at 3 months after treatment. And then as a other reminder, if you are doing pharyngeal swabs for gonorrhea, you actually want a test of cure at 7 to 10 days, just given how high risk that infection is, to make sure that there was not a treatment failure, and then again, 3 months after treatment. So for you both, what are strategies, and I'll start with you, Dr. Stewart, that you found effective to improve retesting rates in your population?
Yes. So what we do is I put in a tickler into our EMR. We need to, use every opportunity to be able to ensure that patients come back for this. And so I will put a tickler in our front desk, make sure that they get an appointment before they leave. And then, of course, if they miss that, which many times they do, that we put out reminder calls. And also not forget that we need to educate the patients before they leave that either they need a, test to cure or repeat testing for the infection that they have been found to have. So the biggest thing is putting in reminders within our electronic medical records and then following up on those.
Dr. Chaffee, anything to add?
Yeah, no, I think just setting up a workflow like Ada mentioned, because it's however you do that, we schedule a follow-up appointment right then and there, whether we're treating over the phone, which is less ideal, but having the patient come in and ideally their partner come in, because if their partner's positive, they need to be rescreened as well. Also, I think the most important thing is the education part, because there's other things we can be discussing. That we could have a whole talk about DoxyPEP and PrEP, but ideally you're retesting for things like if you didn't test for trichomonas at that first visit and they were positive for chlamydia, when you retest them, you want to add in the trichomonas test because more likely they could be positive. And we see that. We see there's undiagnosed trichomonas infection at the follow-up rescreening visit. And you want to rescreen for all the infections because as we learned, if you have one, you're more likely and at higher risk of having others. And so kind of thinking that way, I'll say, we've had, of the HIV positive young people we've had, their only risk factor was having had a chlamydia infection. So really broadening what we're testing for and then talking about these other modalities of prevention, which don't include just condoms. Obviously, condoms will prevent all of these infections, but talking about things like PEP and DoxyPEP to prevent future sexually transmitted infections.
Yeah, and that's a perfect segue into kind of wrapping up that continuum of care and thinking about the protect piece after retesting and kind of getting it back into the awareness pipeline is recognizing that this is one part of the strategy, right? Testing and treatments for asymptomatic or symptomatic patients and building awareness around the importance of this is a piece, but there are really exciting new long-term prevention strategies. And, when we were kind of planning this discussion, all three of us talked about how bacterial STI infections, a single bacterial STI infection is an indication for somebody to be offered PrEP, right? So pre-exposure prophylaxis for HIV. And we've all unfortunately seen patients who have been diagnosed with HIV who their only kind of pre-indicator was a recent bacterial STI infection. And so things like DoxyPEP, so providing doxycycline before, or around the time of sexual activity, post-exposure, right? So it's, around the time of or after sexual activity, giving doxycycline to reduce the risk of bacterial STIs. There's so many tools that are coming into our armamentarium of STI prevention. And, we had a discussion about if you're going to be doing STI care, like, again, the bare minimum is you should be able to, appropriately screen people and have a normalized conversation about sexual health and know what the treatment guidelines are, right? That is obviously expedited partner therapy. But I would also say it is necessary that you understand what some of the new strategies are. And if you're not doing them, maybe in your practice, that you know where to refer patients so that if you do get a positive result and you're treating it, that you already have that, point in your mind. You're like, oh, I need to be talking to this patient, referring them to talk to somebody about PrEP. Dr. Stewart, you said you guys have a new policy or process in your office about who gets referred to you.
Yes. So anyone who has a positive STI gets referred to me for PrEP. They get a phone call where they're offered to come in and discuss PrEP. And I tell you, it's been that individuals who we may not have had that conversation about PrEP before, we are now able to get them in and get them started on PrEP. It doesn't matter the age, because remember, PrEP is for anyone as long as they weigh over 35 kilos. And I tell you, some of these young folks are much larger than that. So we have been able to implement that within our practice and get individuals, educated about STIs, about prevention, and actually get them started on one of the prevention modalities that are available right now.
Yeah. Dr. Chaffee, anything to add kind of beyond testing treatment that you have found impactful in just talking about sexual health or promoting sexual health in your practice?
I think, and thanks for asking that question, because I have a colleague right now who didn't know about some of the new PrEP options. And you're going to have patients that are going to be approaching you. One, they may know about the new modalities. They may understand them before you do. So even if you're not going to be, because it is follow-up, you have to see patients every 3 months, but you're doing the whole STI care and screening each time, but at least know where you can refer, so that if patients do want this, and they may have made their own self-assessment about what they want to be safe about. So being able to offer it, I think, is important. And again, there's a lot of new things out there. And so I welcome people to do some more of their own education and figuring out. I have patients coming in, I'm like, oh, what is DoxyPEP? What had happened? And I'm like, okay, this is great. And when this data came out, and patients were coming in requesting it. So again, it's important, because even though we may know some of the things, your patients are probably sometimes, especially with the internet the way it is, and networks the way they are, and their partners are on, taking these medications. They're like, well, I need to do this too. So I think it's important for us to know about this, so at least we can educate them of where they can get the care, or if you want to go ahead and start providing sort of this wider wealth of tools that we can use to help prevent sexually transmitted infections. Just, start learning.
Agreed. Absolutely. And I think, this conversation has, been very focused on very practical management of STIs. And that is, I think, a cornerstone of sexual health. But I also think about this as an opportunity, right? When you've developed this relationship with a patient, you've taken care of them for chlamydia or whatever it is, that's also an opportunity to talk about like their overall sexual health, right? It's an opportunity to talk about healthy sexual relationships, coercive sexual relationships. I think about menopausal symptom management and the quality of their sex, or what's maybe a barrier to having healthy sex right now. Like, there's so much more that goes on to like the general sexual health continuum and their overall health in general, that maybe starts with having, being really good at just managing STIs, right? And talking about it and screening for it and just bringing up the concept of sex as part of their health, right? Has really far-reaching benefits to their health and the health of their relationships and their community. So I really appreciate both of you for this conversation. I think this is a really important topic, and it's, I find that the more you talk about it, the easier it gets to talk about it. And I think that's true for our trainees. It's true for clinicians who are, new out in practice and building a practice and building their relationships with their patients. And even for those who've been in practice for a long time, to, we can learn new tricks. We can learn about DoxyPEP and PrEP and keep expanding our knowledge to protect patients. But thank you both so much for joining me today. Thank you all for joining this discussion.